we are going to begin with the first session, that is on AFC and beyond, modern approaches to ovarian reserve assessment. To speak on this, we have Dr. Rubeena Zainab, who is affiliated to Milann Indiranagar, and she is a consultant reproductive medicine. She is also a MRCOG and fellow of reproductive medicine. Her topic is on AFC and beyond, modern approaches to ovarian reserve. Over to you, Rubeena.
Thank you, ma'am. And thank you to all of you for being present here on a Sunday morning. So on that note of gratitude, I will be starting off today's session with a very basic evaluation of ovarian reserve, which is such an essential part of our everyday practice. So for just an introduction, what is ovarian reserve? I'm sure all of you are aware of it. So what is ovarian reserve? It is the size of the remaining ovarian follicular pool, and it's also the ability of the ovaries to respond to exogenous gonadotropin stimulation. So we know that there is a difference between the quantity and the quality of eggs. Quantity only refers to the number of eggs in the ovaries, and it is a limited supply for a woman, whereas the quality determines the egg's genetic makeup and also how viable the pregnancy that is going to result from the treatment is going to be. So just a brief overview of the classical tests which used to be done for ovarian reserve. We had the biochemical and the biophysical tests. The biochemical tests made use of lab parameters. Biophysical made use of ultrasound. So under the biochemical tests, we had the static test and the dynamic test. The dynamic test, like clomiphene citrate testing, is no longer done because we have better assessment tools. The static tests, which we most frequently do, are AMH, day 2 FSH, estradiol, and inhibin B. Coming to ultrasound aided evaluation, we have the antral follicular count and the ovarian volume. So the goal of evaluating a couple or a lady for ovarian reserve has changed. It used to be done just to predict the quantity of the primordial follicle pool. But now there has been a paradigm shift in why we do this test. There are several reasons why we now do the ovarian reserve testing. One is to individualize the ovarian stimulation. It's called as individual controlled ovarian stimulation dosing. Screening for primary ovarian insufficiency. It also helps us to counsel the couple at the outset and tell them about what they are likely to expect from the treatment, and predicting ovarian age rather than just the chronological age. So we all know that the most important determining factor for success in IVF is the biological age of the woman. And as you see in this graph, this is done in Indian women by Arora S. et al. In 2025. There is a rapid decline in the AFC after the age of 35, and sometimes even earlier, probably in the early 30s. And loss of follicle accelerates around this age and precedes menopause by about 10 to 12 years. Going back to the traditional test, which is FSH, we know that FSH, when it is elevated, it becomes an early sign of reproductive aging in women, making it a logical marker for detecting diminished ovarian reserve. But it has the disadvantage of being having a wide intra and intercycle variation, and that's why it has a limited value as a screening test. For optimal accuracy, it has to be measured with by cycle days 2 or 3, neither earlier nor later, and FSH levels above 10 international units per liter, typically 10 to 20, are highly specific for predicting a poor ovarian response to stimulation. Coming to the next test that we usually do is estradiol. It's basal serum estradiol alone in isolation, that is, it's not a reliable test for ovarian reserve, but it can help in interpreting basal FSH levels. So you have to interpret both of them together. An early rise in estradiol, such as advanced follicular development and early selection of a dominant follicle, which is common in aging reproductive women. This early estradiol elevation suppresses the FSH, potentially masking a high FSH level that would have otherwise indicated a diminished ovarian reserve. So, if FSH is normal, but estradiol is high, more than 60 to 80, there is an increased risk of poor response to stimulation. So this should give you an indication of what is going to happen in the cycle. Coming to AMH, which is one of, there are two important markers that we rely on nowadays, which is AMH and AFC. So AMH is produced by the granulosa cells of preantral and small antral follicles, with the small antral follicles likely to be the primary source due to their higher granulosa cell count and more developed microvasculature. So the number of small antral follicle correlates with the residual pool size, and AMH levels decline progressively, becoming undetectable near menopause. Lower levels are generally linked with poor ovarian stimulation response, reduced oocyte yield, embryo quality, and reduced pregnancy rates. It's a more sensitive measure of ovarian reserve than FSH, and it tends to decline before FSH rises. So you would like to do an AMH in preference to an FSH. And one advantage of AMH is it does not require day 2 or day 3 testing. Unlike FSH, it can be done at any day of the cycle. The current ASRM position, American Society for Reproductive Medicine, what they have proposed in 2025 and 2026 is that it is a cycle independent marker. So while FSH requires early follicular phase measurement on 2 occasions to be sure that there is a problem, AMH provides a reliable snapshot of the functional ovarian reserve at any time. So what the practice committee says is AMH values are equally valid at any point in the menstrual cycle. A study published in Frontiers in Endocrinology in 2026 notes that there might be some fluctuations of AMH up to 20%, which is rarely enough to reclassify a patient from normal to poor responder. So those fluctuations are not so severe that you have to change your treatment protocol. One disadvantage for measurement of AMH is the contraceptive caveat. That is, if hormonal contraceptives are used for a prolonged duration of time, AMH levels can be suppressed to about 30%. So you need to give a break of 2 or 3 months before you repeat the AMH. How does it matter to us as clinicians? So looking at the age-wise distribution across the various ages, you can look at what the median AMH is and what the normal range is. This is in Indian women. And you can see that the AMH decreases from 4.2 between 20 to 25 to 41 to 45. 0.42 in the 41 to 45 age group. Coming to the ultrasound evaluation, we have the antral follicle count, ovarian volume, ovarian Doppler assessment, of which antral follicle count is what we most often follow. Antral follicle count is the sum total of follicles in both the ovaries measured by transvaginal ultrasound in the early follicular phase. It shows low intercycle variability and high inter-observer variability. So between two doctors who do the scan, there can be some difference in the count. It strongly correlates with ovarian reserve, considered a reliable predictor. This shows the age-wise distribution of the AFC. And what we are interested in is advanced AFC. Now, it's difficult to manually count the follicles accurately. So what we are making use of is 3D and 4D ultrasound. So what's called as sonovac, which makes use of color imaging. Why it matters is it eliminates inter-observer variability, gives you a real-time volume calculation of functional reserve, and integrates vascular indices as well. So you can, this is the normal AFC count that we do on a 2D ultrasound, and this is how it appears on a sonovac, where every follicle is color-coded and the machine does the calculation for you. Clinical application, it helps you in assessing who are high responders and plan their treatment to prevent OHSS, choose the kind of trigger, normal reserve 8 to 15, diminished reserve 5 to 7, and severely diminished reserve less than 5, helps you in counseling the patient. So what are the modern approaches, how AI is useful in IVF? So there is something called as AI-powered radiomics fusion frameworks. Fusion models that combine deep learning with radiomics from routine 2D ultrasound. They outperform traditional single marker assessments by nearly 8%. So what are radiomics? It's a high volume extraction of quantitative data from medical images, essentially turning pictures into data. How it helps? It assesses stromal health, so they analyze the texture of the ovarian stroma, they predict oocyte competence by using radiomic features of the follicular wall This likely to predict an M2 egg or a mature egg. And it for standardizing POI, that is primary ovarian insufficiency diagnosis. There's something called as explainable AI for trigger timing. There's a study done by the Imperial College. 5 minutes, okay. This showed that we identify traditionally any lead follicle, 2 to 3 follicles more than 18 millimeters, we give a trigger then. But what this uses is intermediate follicle cohort of between 13 to 18 millimeters, maximizing the retrieval of M2 eggs. Okay. Then for menopause predicting, there are foundation models which predict the menopause before it actually occurs, which helps in fertility preservation. And there are knowledge-driven graphs for low prognosis, which are being used. They take data from history, previous cycle failure, comorbidities, and then they give you a protocol recommendation for all these low prognosis patients. And they match this against thousands of similar biological twins.
We have to be a little strict about the timings. We are already late. We started late. So just you can sum up the thing.
Yes, ma'am. The summary last. Ovarian volume is no longer used. It's a surrogate marker. And limitations are inter-observer variability. So which is better? Both of them have their own advantages. I'll come to that. A study done by Salemi has told that combining AMH and AFC has the highest sensitivity and specificity. And combined models which integrate age, BMI, prior response, and use of AI are better in predicting the ovarian reserve. So just the clinical implications for us, use them together for guiding your counseling and dosing. It's useful for Poseidon classification, and do not use alone for fertility prediction. Thank you.